Today we have our distinguished guest, Indian expert, Dr. Rajesh Badani. It is my honor and privilege to introduce a highly accomplished clinician, teacher, and researcher in the field of cardiology, Dr. Rajesh Badani. He is a distinguished senior consultant, interventional cardiologist, and electrophysiologist at Aditya Birla Memorial Hospital, Pune, where he also serves as a cath lab coordinator, administrative in charge, and patient safety officer. He completed his MBBS from SET GS Medical College, Mumbai, followed by MD Medicine from Grant Medical College and DNB Medicine in Cardiology from the National Board of Examinations, Delhi. He further specialized with a fellowship in electrophysiology at Care Hospitals, Hyderabad. Dr. Badani has over 10,000 diagnostic catheterizations, 2,000 plus coronary interventions, including complex CTO and bifurcation angioplasties, more than 2,000 pacemaker implantations, along with extensive experience in AICD, CRT, and valvotomy procedures. His expertise also covers a wide range of non-invasive cardiology diagnostics, including echocardiography, Holter test, and tilt test. He has held key positions in professional bodies, namely President from 2012 to 13 and Secretary from 2009 to 10 of the Cardiology Society of India, Pune chapter, and is a fellow of the European Society of Cardiology and FSCAI. His notable research contributions include Brugada syndrome, atrial tachycardia, electrophysiology case studies, mutations in myosin 7 and troponin I3 genes in hypertrophic cardiomyopathy, oxidative stress in cardiovascular disorders, diabetes, and anemia. He has a strong research portfolio, having authored numerous peer-reviewed articles and conference abstracts, including work published in top-tier journals such as the Journal of the American College of Cardiology and also the Indian Heart Journal. His research span areas from electrophysiology and pacing to genetic studies in hypertrophic cardiomyopathy. He is also the recipient of the D.P. Basu Award for the best paper at Cardiology Society of India in 2008 and continues to contribute actively as an invited faculty at national and international conferences. Through his blend in clinical expertise, leadership roles, and impactful research, Dr. Badani has made significant contributions to the advancement of cardiology in India and beyond. Now, I request our course coordinator and our HOD of Department of Zoology, Professor Narahari Grampurohit sir, to welcome and felicitate Dr. Rajesh Badani. Thank you, sir, and thank you, ma'am. Now, we begin today with our Lecture 3 of Day 2 course, Diagnostic and Genetic Aspects of Hypertrophic Cardiomyopathy by Dr. Rajesh Badani. Sir, please come and grace us.
Okay, good morning all. First of all, I should thank Dr. Varsha ma'am as well as the Department of Zoology for having invited me here. I think our association almost dates more than around 8-10 years back when we probably started doing, brief genetic work in hypertrophic cardiomyopathy. And I believe it's great to see that the department is really doing very good work in basic sciences, genetics, and particularly focus on the hypertrophic cardiomyopathy. And this program, when I saw the agenda, I think it covers almost every single aspect. Today's talk that is going to be is on genetics in hypertrophic cardiomyopathy. What are the clinical implications for the diagnosis and management? So my key discussion will remain to genetics, which probably, you guys, and I think Professor Saktivel is here. So maybe, apologies if I am not an expert. That is the thing in genetics. Though whatever is there, it's more of a clinical association. Little bit of terms I may still not be really very much aware, which I think will take the experts' help. So hypertrophic cardiomyopathy is the prototype genetic cardiomyopathy. Almost 60 to 70% of the people with hypertrophic have got an association of genetic association. It is there. It runs in family, predominantly an autosomal dominant condition. That means that the offspring has a 50% chance of acquiring the gene from the parents. Now the only thing is that the moment the person has a gene which is a genotype positive, phenotypically how the patient will behave, that is the most interesting variability. Many people don't present anything till 3rd to 5th decade. Some people manifest very early in childhood, some people in middle age, but average is 3rd to the 5th decade. So that is between 25 years to 45 years is the time when the diagnosis, symptoms and other things come up. Now understanding the genetic background can enhance our insight into its pathogenesis, number one, and the potent therapeutic targets. While the clinical presentation is variable, remember why it's variable, because you can have a person who is absolutely asymptomatic versus the person can present with sudden cardiac death. And advances in molecular genetics have really revolutionized. In US, I think from where Professor hails, they have a very, very dedicated way of evaluating hypertrophic cardiomyopathy from animal to humans. They have got a great genome project. They have got multiple genes which have been identified, but in India, we are still at the inception stage. Now, this is very, very interesting to understand that the etiology of hypertrophic cardiomyopathy can be considered infective, hereditary in 70%, hypoxia and oxygen imbalance has been considered one of the etiological processes. Then comes the hormonal imbalance. Many people in presentation, now these on the left hand side are the etiology, this is the presentation. Majority are asymptomatic. Somebody can have a ventricular tachycardia. Atrial fibrillation is also very common. They can have thromboembolic episodes and stroke which can occur because of AF. And the most interesting aspect is the commonest cause of sudden cardiac death in people below the age of 35 years is nothing but a hypertrophic cardiomyopathy. People who have had, you have seen soccer players who probably have fallen on the ground, not woken up, or somebody was defibrillated and they got alive. Majority, so these were undetected HCMs going on, and many of them can be sporadic. So they may not have a family history. The person index case may present with hypertrophy, syncope, resuscitated cardiac arrest, and that's when you diagnose this patient. That is why this condition becomes very important from genetics to the clinical presentation to be identified. So hypertrophic cardiomyopathy is an abnormality of sarcomeric gene proteins which are there predominantly. Non-sarcomere and mitochondrial account for less than 20% or 5% or 20% of the total number of genetic which is there. So if you want to understand, this is the sarcomere where these are the thick filaments which are blue, the green are the thin filaments, or the thick are called obviously myosin, thin are called actin, and the actin myosin complexes, when they interact, that's when the excitation contraction coupling occurs, a heart contracts, and probably we see the contractile phase. So that is how at cellular level these are the things. There is something called as a M-line protein, and these are calcium related genes. So commonest are the thick filaments. Almost majority, more than 40% of genes come from this, particularly the myosin heavy chain 7 or myosin binding protein C3. These are the two names that you should remember very clearly. Majority of HCM is because of these two genetic abnormalities. Thin filaments will come to troponin T, troponin I, troponin C, and you have myosin light chain 2 and 3, which are obviously also. So these will account. So total of 5 to 7 and to 9. 8 out of these 9 genes are definitively associated with hypertrophic cardiomyopathy. All others may not have a very strong association, which are these. This is titin, Z disc proteins, as well as the calcium and the M line. These are all very rare. Z disc, particularly CRSP3, is very strongly associated with sudden cardiac death, and now we have therapy, gene therapy, which is probably being working on that. I'll come to it later. Now, how does an abnormality in the genetic association cause an abnormal phenotype presentation of hypertrophy and hypercontractility? So for all of you who have been there yesterday in Dr. Chauhan's talk, it is very clear that in hypertrophic cardiomyopathy, you have higher contraction which is there. Why do you have higher contraction? Actin and myosin are strongly associated, and when they both get in contact with each other and there is an ADP-ATP conversion, that is when the contractility improves. In the upper panel, just for simplistic purposes, these are the only two myosin is in touch with actin. The red and the green are in touch with each other only in 2 of these. Here, this is the HCM heart 1, 2, 3, 4. So when you have a larger component of actin myosin contraction, the chances of higher contractility becomes more. At the same time, the relaxation phase, which is the diastole, gets affected. And that is the reason hypertrophic or any heart which is thick does not relax very well. It contracts excellently, but the relaxation is very slower. Those on echo and other features we identify, but from this perspective, we need to understand this is the basic pathophysiology, how does it occur. Now, location within the cell, if you take sarcomeric or the contractile protein, Z, look at the incidence, 40 to 50%, 35 to 40%, 7 to 15 is troponin T, troponin I is 3%, myosin light chain is 1 to 2%, all others are below 1%. So that's why I am telling you that if you are able to identify these 7 or 8 genes, that's why the gene panel, when we ask for a genetic testing, takes care of all these things, because your majority of cases are going to be there. Calcium binding protein, it has a definitive evidence, and it is, PLN, phospholamban. It has got a specific cardiomyopathy, which we call it as phospholamban related cardiomyopathy, but that is very rare. And there is only one gene which is probably X-linked. Where it is gone by? Here it is. LIM domain protein, which is a Z disc protein, which is FHL1, and it is probably the only one which is an X-linked. All others are autosomal dominant, and few of them, the uncommon ones lower down, are autosomal recessive. So your predominant understanding should be it's an autosomal dominant. Family history has to be very strong. There is a 50% chance, and few of them can present with sporadic cases. They may not be having any past history. Now, list of the main genotype, when you say, these are called as hypertrophic cardiomyopathy mimics. On echo, I have a thick septum and a posterior wall. So every thick septum does not mean it is hypertrophic cardiomyopathy. It could be one of these. Metabolic regulatory, lysosomal or glycogen storage, lysosome, RAS MAPK pathway, or others like transthyretin, which we call it as cardiac amyloidosis, and mitochondrial diseases which are there. All of them are definitive. Lysosomal as something called as LAMP2, and PRKAG2 is the commonest 2, which is called as PRKAG2 syndrome definitive. The Danon disease is X-linked. Anderson-Fabry, which is seen, these are all in young children. So any child you see with a very hypertrophied ventricle, you straight away think of this, do their echo, do their ECG, ask for family history, get your genetic analysis, and that's when you can prognosticate whether this child has a high risk, low risk, intermediate risk of sudden death or future perspectives, what you need to do. Now this is something, it's a busy slide, but this is just to understand that when we talk of genetic variants in the main genome, when we talk about, the slide is busy, but this is single nucleotide variations which we talk about. That is the most common type of abnormality. And then we talk about the other, which is uncommon with hypertrophic. So I'll skip this for the purpose of discussion, but you have to understand what is the abnormality. There is something called as an intron insertion or deletion. Then you have mutation. Then you have a lot of other terminologies which I am not very conversed with, but this is the commonest, single nucleotide variability. That is one of the commonest things that we need to know. Now, categorization of genetic variant for clinical application. So, when I see a genetic report as a clinician, what am I going to look at? These terms need to be. There is something called as a pathological variant, PV, or there is LPV, likely pathologic variant. Variants for which there is a strong genetic evidence for their involvement in the pathogenesis. So, that means in the genetic report, if it comes as a PV, that means this gene has got a very strong association. So, genetically this patient is genopositive. Clinically, as a doctor, I have to look whether he has hypertrophic cardiomyopathy. I'll ask for family history of death. I'll ask for syncope. I will ask for symptoms, dyspnea, fatigue, tiredness, all those things. See, PVs are predicted to distort the structure and function of the encoded proteins, often leading to premature truncation of protein and haploinsufficiency. These are called as frame shift variants, such as indels means deletion and insertion, and splice junction variants. Variants leading to gain or loss of a stopped codon. There is a CAD score which is called as a combined annotated dependent depletion score. It is very rare in the general population because means sporadic cases are rare, but familially this one is a very strong association. LPVs have characteristics similar to this. Typically they involve genes that are partially intolerant to LOF, is loss of function variants. Then you come to function variants. This is very important. A genetic report may tell you variants with unknown significance, VUS. So means that is not very strongly genetically associated. And if you see here, undefined functional or clinical significance, common in the genome but often located in intergenic regions or introns. There is something called as a likely benign and benign variants. These are common in the general population. Means in the population there are many people who will have hypertrophy. Athlete's heart and hypertension are two common conditions in the common population that you will see. So they will have this variety, but genetically they don't have PV or LPVs. So that's why their geno-pheno correlation is not strong. They will be genotype negative, but phenotypically they may behave like hypertrophy. Their prognosis is much better than the genopositive, phenopositive individuals. Now this is exactly the nutshell of the last two slides. On the left hand side, remember, this is population frequency of the genetic variants. Hypertrophy in response to external stimuli. Hypertension will cause pressure overload on the ventricle, which will increase the septal thickness, and athlete heart, you will have physiological hypertrophy because of excessive exercise. So any external stimulus causes hypertrophy. It doesn't have a genetic correlation, but it has a population may the number is much more. Number of pathological variants are numerous, but penetrance genetically is very low, and evidence for causality is only association. It is not a strong association like here. If I talk here, monogenic and oligogenic hypertrophic cardiomyopathy, the effect size of gene variant is very high, but population frequency you will find is very less. They have pathological variance is only one. That means I told you like myosin binding protein C3 or heavy protein is present, but penetrance is very high. It can directly go across families. That's why the familial transmission is high and causality is very robust. Here it is moderate, weak and only association. So this is to differentiate a genotypic versus a phenotypic presentation and how you will intermingle with these two things and how I am going to do, how as a clinician we are going to evaluate. This is very, very important. This is also a complex side in the pathogenesis of hypertrophic. So that is why this condition is very interesting, because the person may just be asymptomatic, but if I pick up that this hypertrophy is pathological, and if the person tells me that he has a strong family history of sudden death and I try to get a gene analysis, there are certain genes which are directly proportional to history of sudden death. But on echo, the hypertrophy is very less. That is what is very important to understand. So see here, at mRNA level, it's a stable expression or transcription efficiency or non-stop decay or no-go decay, mRNA stability and chromatin structure. These are the pathologic variants. Now what happens at protein level? You have stable expression, that is I think what Dr. Saktivel was talking about, poison peptide, translation efficiency. So what does it do in the sarcomere assembly? It can be efficient or inefficient ATPase activity, actin, myosin. So what happens from the genetic level? What happens to protein? From protein, what happens to the cellular level of sarcomere? From there at cell level, what happens? Myocardial level, what happens? Histopathologically, there are three abnormalities. Number one is myocyte hypertrophy, myocyte disarray and interstitial fibrosis. So if somebody only has hypertrophy, he will on echo behave as cardiac hypertrophy or LV outflow tract obstruction. He can present with heart failure with preserved ejection. He can come with breathlessness, edema, feet and all that. He can have ventricular tachycardia or atrial fibrillation and sudden cardiac death. So this is the variability from genotype abnormality to the phenotype presentation. This is what happens, and it is such a mixed interplay that it is not 1 + 1, 2, it is completely different. That is why this condition is very interesting and you need to as a clinician suspect all these things and try to evaluate. So what is the aim is to synthesize the current evidence what we discussed into the genetic architecture of HCM, including the sarcomeric and non-sarcomeric variants, inheritance pattern, autosomal dominant, autosomal recessive, X-linked or sporadic, genotype, phenotype correlation, and implications for diagnosis, prognosis and treatment, which I will come to it at the end of the thing. Now this is very important, role of genetic testing and variant interpretation. So genetic testing is recommended definitely for index cases and at-risk relatives to enable early detection and surveillance. High throughput panels, whole genome sequencing enhances detection rate to identify structural and deep intronic variants, improving the diagnostic yield to 12% as compared to conventional panels. Now interpretation, I was telling you, you will have something called VUS, variants of unknown significance, remains a challenge. And all these guidelines help to optimize the classification accuracy and the clinical utility. How am I going to use this report and how am I going to treat the patient is different. Now clinical utility of genetic testing is facilitates diagnosis in atypical cases, guides cascade testing in families, supports reproductive. A pregnant lady is there, what are you going to make a decision? You want to continue pregnancy, abort the child, what care are you going to take, all those things. Now what does it do genetic? It will help differentiate thickened myocardium such as phenocopy diseases like amyloid, sarcoid, Fabry's, hypertensive, athlete's heart and it guides the family surveillance. For pregnancy planning during genetic counseling, it should be clearly communicated to the proband and their partner about the inheritance. It's autosomal dominant. I have to tell that there is a 50% chance in the offspring that your child may carry this gene, and the potential for phenotypic development. Tomorrow I am transmitting the gene. Which gene will have a better penetrance? Also, I should be able to talk to the family, and then only the family can take a call of continuation of pregnancy or not to. Now, genotype-phenotype correlation, mind you, is one of the most difficult situations. A person who is genotype positive, phenotype he can be negative, intermediate or positive. That is how. So what certain mutations correlate with distinct phenotypes like myosin heavy chain 7 tend to produce earlier and more severe hypertrophy. So they will present early, hypertrophy will be significant. Significant means more than 20 millimeter of septal thickness is called severe hypertrophy, and that is directly linked to increased risk of sudden cardiac death. MYBPC3, that is myosin binding protein 3, are associated with late onset disease and may exhibit incomplete penetrance. So phenotypically the features may not be very classical because they are presenting late, third, fourth decade. So it will be very difficult at a 45-year-old person who only has hypertension and hypertrophy, whether he has features of HCM. Young people, it's very easy to pick up. Why? Because I am supposed to be talking about SCD, ventricular arrhythmia. Should I put in an ICD in that patient or no? This is very, very interesting. TNNT2, they are often linked to a high risk of SCD despite minimal hypertrophy. A person may only have 12 or 13 millimeter septal thickness, but the risk of SCD, if he is of this genetic variability, is very high. So if I have this genetic variation, I will straight away discuss with the family that I need to put in a device which is called implantable cardioverter defibrillator to reduce the risk of sudden cardiac death. Now, genetic contributions to HCM phenotype. There was a Korean data which suggested a comprehensive genetic analysis of 212 patients. 82 were nuclear DNA, that is sarcomere associated genes, phenocopy genes and mitochondrial genes, and 37 mitochondrial DNA variants. This study revealed that pathogenic variants in sarcomere genes were more prevalent in non-apical HCM compared. So, it means very clearly somebody who has a sarcomeric mutation will have classic reverse type echo, this asymmetric septal hypertrophy. Septum will be 20 millimeter, posterior will be 12 millimeter. That's why we call it as ASH, asymmetric septal hypertrophy. Septum is more thicker than the posterior wall. That is more common in the regular cardiomyopathy compared to apical HCM. Interestingly, apical exhibited a higher frequency of troponin I mutation and lower frequency of myosin heavy chain 7. So you have to understand MHC and myosin binding protein, both of them which are of the thick filaments, directly are proportional to a high thickness, high fibrosis, high risk of sudden death, rather than others which probably have a lower risk. Additionally, mitochondrial gene mtRNR2 was associated with apical hypertrophic. This has a distinct genetic profile, and apical HCM has got lesser mortality, lesser risk of sudden cardiac death. Japanese have got a higher incidence of apical HCMs, and Indians also quite a bit, but the risk of sudden death is much lesser. So these findings highlight the heterogeneity of HCM and underscore the importance of considering both sarcomere and mitochondrial gene variants in understanding its phenotypic diversity. Impact of sarcomeric mutation on myocardium. So several studies confirm that sarcomere mutations were related to increase in myocardial fibrosis. Kim investigated the effect of sarcomere mutation on myocardial mechanics and fibrosis pattern using cardiac MRI and echo. What did the study show? That sarcomeric mutations have lower circumference strain, that is low GLS, global circumference longitudinal strain is lesser, LV function is lesser, and they have got higher prevalence of mid-wall fibrosis. More the fibrosis, more the chance of arrhythmia, more the chance of sudden death. These alterations were independent of the extent of hypertrophy, indicating a direct impact of genetic mutation on. So that means a mutation can give you a clue. So I will probably do an echo, I will do a cardiac MR, I will do genetic analysis, try to risk stratify my patient and then take it further how to go about. This study provides further evidence of pivotal role of epigenetics for variable expressivity. Environment factors, hypertension, exertion, metabolic stress also significantly contributes to the disease variability. Now genotype positive but phenotype negative, high intensity athletic training or pressure overload may precipitate hypertrophy or arrhythmic events. That is what is important. So you only treat hypertension, let that athletic person reduce his physical activity, probably the hypertrophy is reversible, it can come down. So he is not the HCM category. Korean National Health Insurance tells you that association between body mass index and clinical HCM after the hazard ratio was almost 1.063. Metabolically unhealthy participant had higher incidence of HCM than healthy people regardless of obesity status. So somebody who is physically active, definitely the chances of developing HCM chances are lesser. So this means even when I am harboring a gene, my clinical physical activity and my lifestyle has got a great impact in what I have my presentation in the subsequent 2 or 3 decades. So this is also very, very relevant. So presentation of apparent can be sarcomere positive, sarcomere associated and monogenic hypertrophic cardiomyopathy. Syndromes, as I told you, they are mimics of hypertrophic cardiomyopathy, and polygenic, this is more of on the future role of polygenic risk scoring which we are talking about. And these are strong evidence for pathogenicity and limited evidence which I already have spoken about it, and percentage we have talked about. So if I talk about 2 or 3 genes, these 3 or 4 genes together, more than 90% of genotype positive cases will be picked up. And these are all the HCM mimics. Now there is a very interesting score that we call it as model for positive genetic assessment. If my age is below 45 years, 1 point. If I have septal thickness more than 20 millimeter, 1 more point. Family history of HCM, 1 point. Family history of sudden death, 1 point. Reverse curse hypertrophy, 1 point. So that is 5. But somebody who is having history of hypertension, it is -1. So range is from -1 to 5 points. Anybody who has 5 points, there is an 80% chance that my genetic testing will be positive. So history, if I have a family history of SCD, if I have a family history of hypertrophic cardiomyopathy, I am younger, below 45, I am having a septal thickness of 20 millimeters. If my score is 4, I have a 70% chance that genotypically I will probably have a positive result. Very simple. That is the reason that younger people, the chance of a genetic yield is higher. Somebody who crosses 40, 45, it's going to be a very difficult to pick up. So this is something which is very, very important. So now in a nutshell, genetics, these are established blue, diagnosis confirmation and family cascade screening. You need a genotype specialist to probably define how am I going to do the cascade screening. Means family tree needs to be done 3 generations before, 3 generations next, and then come to a conclusion what you should be doing. Polygenic risk score are still being established. Risk of phenotype development, tailored frequency in sarcomere negative families, interaction with all of them are questionable. We don't know a correlation. Targeted therapy, now we have pharmacogenomics, or we have gene therapies, which I'll come to it in later on, and risk stratification. Today, if somebody is genopositive but phenonegative, I cannot define the risk of SCD in that patient, and I cannot treat the patient only on genotypic positive factors. That is very important. And this is how it happens. When I have a protein and there is a no mutation, this is how the protein is developed, and this is a normal heart. The moment it goes, this is called as a truncated protein product, and this truncated protein activates the UPS pathway, which is going to be the ubiquitin pathway which we are talking about, and that directly results in hypertrophic cardiomyopathy. And this is also very important. How does history help me in genotype positive proband? If my family history is positive for HCM or SCD, reverse curve, female sex, septum more than 20, below 45, absence of hypertension, these are all positive signs that my genetic yield will be higher vis-a-vis all the others. The genetic yield may be lesser. This is exactly symptomatic. These are all the genes which have been identified. These purple and this is up to from here to here is the hypertrophic cardiomyopathy genes, sarcomere, filaments, M-band, Z-disc and sarcoplasmic reticulum and mitochondria. RAS, lysozyme, Z-disc are all related to symptomatic LVH but non-hypertrophic cardiomyopathy gene. So this is how we will be talking about pathogenic or likely pathogenic variants. All relatives, first degree relatives have to be tested. VUS, counsel on uncertainty, consider cascade with caution. Negative test, no further testing for relative. And genetic test not done, obviously we are not. So what you do is, in the families you need to look at ECG and 2D echo. Echo can be done, ECG can be done yearly. Echo can be done once in 2 years or at the most once in 5 years, just to pick up whether this person is developing signs of hypertrophy on the 2D echo. Genotype guided therapy now we have. So current treatment remains largely phenotype based like beta blockers, calcium channel blockers, disopyramide, septal reduction therapies like alcohol septal ablation, myectomy and ICD. These are all the medical and the non-medical surgeries. Mavacamtan is the newest drug, which is a myosin ATPase inhibitor, has shown promise in reducing hypercontractility. So in sarcomere genopositive, mavacamtan achieved primary composite with an odd ratio of 4.43 compared to 2.5 in the sarcomere genonegative in the explorer. So somebody who is genopositive, you straight away start mavacamtan, the chances of sudden cardiac death and the hypertrophy reduction will be much better than a genotype negative. Stronger and more sustained response has been observed in pathologic or non-pathogenic sarcomere, likely pathogenic sarcomere variants. Therefore, genetic testing may be useful in predicting therapeutic response and guiding personalized management strategies, including decisions like septal reduction surgery. Now, in gene therapy, there is a Cleveland Clinic data in 2023 targeting myosin binding protein C3 with an adeno-associated virus vector TN201. Preclinical data support reversal of disease through restoration of sarcomere. So at cellular level, you are restoring the protein expression so that the phenotypically the person doesn't develop. Gene editing technologies like CRISPR or Cas9 and RNA based are being explored for mutation correction or silencing. And these are the 4 varieties of gene therapy. One is called as the gene transfer. You send vectors and it transfers it into the DNA level. Splicing correction, which is called exon skipping. If this red one is the abnormal exon, you take it off. Instead of 1, 2, 3, 4, you have gene splicing 1, 2 and 4. This is mRNA without the mutant exon. The last is the repair which you can do, gene editing, which is the CRISPR and the Cas9 system. And the last is the silencing. At RNA interference you do. So there is a mutant mRNA degradation. These are different genetically based therapies. They are not yet active in clinical practice but going on. So maybe tomorrow genopositive people, before the child is born, you may start this and maybe the person, even though carries the gene, but phenotypically doesn't express this problem. And these are all the therapies. I will skip for the audience or the crowd that we don't have much of. But remember, risk of complete heart block needs to be experienced. And this is ablation versus myectomy. This has got a more stronger benefit. So use it in the youngest people who have a large survival, healthy, long span, active, higher gradient, greater thickness and coexisting structural heart disease. Elderly, low gradient, sedentary, limited lifespan, you just go ahead and do an ablation which is there, which is called alcohol ablation. Now last few slides on genetic and family screening. This is the American Heart Association guidance. These are all class 1 recommendation in patients. Evaluation of family including a 3-generation family history is recommended. Genetic testing is beneficial. Atypical clinical presentation and another genetic condition is suspected, a workup which we do for the HCM phenocopies. Now we have genes for them, so you can do that. Genetic counseling by an expert geneticist has to be discussing. When performing just genetic testing in proband, initial tier of genes tested should include genes with strong evidence. Strong evidence means 8 plus 3, 11 genes or 12 genes if I remember. First degree relative, both clinical screening and cascade genetic testing only when pathologic or likely pathologic variant has been identified in the proband. If it is abnormality with unknown significance, you don't do a genetic testing in their family members. Family with sudden unexplained death has occurred, post-mortem genetic testing also can be done. In patients who have undergone this, serial reevaluation is identified to assess variant reclassification, affected preconception and prenatal genetic as we already discussed. Not recommended HCM who have undergone genetic and found to have no pathogenic variant, they are only benign or like cascade testing is not useful. Ongoing clinical screening is not indicated in geno-negative relatives or VUS patients. And HCM, this I think we have already discussed. This is targeted gene testing, what you are going to do, we have already done that. Hypertrophic cardiomyopathy, this is what you see, apical aneurysm on the MRI, LV systolic dysfunction, unexplained syncope, massive LVH, family history, sudden death, NSVT on Holter. This is for us as clinicians, we need to look at this. If my patient has this, he has a high risk of SCD and he probably can have sudden cardiac death. Now, patient selection for ICD, this is very important. For each device cost you 6 lakh to 8 lakh rupees. If I have to put it in a young patient, I should have very strong evidence that this is going to benefit and it is going to be cost effective. So prior event, SCD, ventricular fibrillation or sustained VT, if it is present, straight away ICD recommended. If not, at least one of the following: family history, massive LVH, unexplained syncope, apical aneurysm, low EF. If it is yes, 5-year risk estimation, it's a 2A recommendation. So ICD is even reasonable in this group. No, if NSVT is present in children or adults, ICD can be recommended, but extensive gadolinium enhancement on MRI may be considered, but if it is not there, an ICD is not indicated. So this is very clear picture that look at all these features, do a ECG, echo, Holter, cardiac MRI, genotypic evaluation, phenotypic presentation, history of syncope, family history, all put together, calculate and then come and let us know how it is. So I'll skip all this. So in conclusion, most common genes identified in non-syndromic sarcomere is MYH7 for beta-myosin heavy chain and myosin binding protein C3, cardiac troponin T and troponin I. These will account for more than 90% of your genotypic abnormalities that you see. They'll account for 90% of genopositive. Finding of pathogenic or likely pathogenic mutation improves the diagnostic certainty, and you need to do family screening or cascade screening and evaluation in the family members with echo, ECG and genotypic evaluation, and accordingly all guidelines recommend genetic testing for HCM. And the future direction is the field is moving towards precision medicine, integrating genomics, transcriptomics and proteomics for personalized care. Longitudinal studies and registries are essential to validate geno-pheno association and assessing the long-term impact of the genetic interventions. Thank you very much for a patient hearing. I think we can take up any questions. Yeah.
We are normally when the patient comes, the clinicians recommend go for the ECG, then for the 2D. Now, when you will be suggesting monogenic inheritance needs to be checked for this particular patient?
So basically, if I have to evaluate the genetic, first of all, I should have a very strong feature. This patient has features of hypertrophic cardiomyopathy. So for that slide which tells you strong factors, a young patient who is below 45 years of age has got a ventricular septal thickness of more than 20 millimeters. He is the non-apical variant. Then I have a family history of sudden cardiac death or a family history of hypertrophic cardiomyopathy. These all features will make it very, very clear that if I do a genetic testing, my yield of a positive result is more than 60 to 70%. So those are the subsets whom on evaluation I will think he should go for a genetic testing.
So, out of those 4 genes, which you will be recommending for the Indian population?
No, but now we have a genetic panel only. So it's not 4 genes, but I will have those 11 or 12 genes which will cover more than 90. That will be troponin C, troponin, myosin, light chain, all will be a part. Now we have a panel.
Yeah.
So that they will take.
But only the known variants will be
Yes.
covered in that.
At that particular time, only the known. So 11 variants of the genes which account for more than 92 to 93% of the genotype issue will be picked up. So you'll pick up at least more than 93%. The other 5 to 7 are very rare. So they will not present at 30 years or 35 years or 40 years. They will present in childhood. So there you have to have a geneticist or a pediatrician also who should be able to pick this up in children. Now this fellow doesn't fit into, and then all of these genetic conditions have got separate clinical associations. Some acanthosis, some neuropathy, somebody has myopathy. So you have to look at not only the heart, but all the skeletal features which should be. So you need to be an expert in genetic suspicion of a rare genetic disorder by which. So as a clinician, I may not be the only person, but I should definitely suspect. So ideally, this should start from pediatrics. At adulthood, 18 years and onwards, I will see the classic garden variety of hypertrophic cardiomyopathy. Obstruction present, septum is thick, gradient is there, mitral regurg is there, and then I will probably take them up with medical treatment and all that. But those, what we are talking of, the rarer variants, they are more into the pediatric age groups which are there.
Okay. And then you can recommend the genetic counseling to those.
So that will be at that particular time we can think about, yes. Yeah.
So when should a person go to a doctor and think about genetic counseling or genetic testing of such diseases?
Ideally, a layman will not go unless and until you have a family history. Like in the past couple of generations, somebody has hypertrophic cardiomyopathy. So today, as compared to the robustness with which US does all these things, India even doesn't have specialty geneticist present. Today I have 1 person or 3 people who are across Pune. So if I have to call them, I have to take an appointment of them to come to my institute. Then I have to have the family sit with me like that. Maybe in US, it's so systematic that from pediatrics onwards, you have a genetic expert. There is a genetic counselor who will look at the history and discuss all this. In India, we have not yet reached that stage. But yes, your answer to your question is, when should a layman go? Is only if you believe that I have a strong family history of sudden cardiac death. So definition of sudden cardiac death is a male below the age of 55 years in your family, maternal or paternal side, has had a death. Male below 55 and female below 65 have died suddenly, not accident related death, not confirmed myocardial infarction, post angioplasty, post bypass related death, not them. If such a kind of a thing is there and more than 2 family members are there, 2 or more, then you have a very strong family history. Then you go to a doctor, get your ECG and echo evaluated whether you have hypertrophic cardiomyopathy. If not, then the next common condition is coronary artery disease. I may be harboring a block. So I will get my 2D echo stress test, angiography, identify the block, treat the block. So that's not a familial condition. So it's very difficult for a layman to reach a doctor. It is only on routine screening. You go for a health checkup. Your echo shows muscle is thick. That's when the sequence, and that should be suspected by the doctor, and he should advise ki Baba, please go ahead and get your evaluation for HCM. That's how it is. But not routinely, it's very difficult for a layman to go, because in the general population, many people have just hypertension. But if you see hypertrophy in somebody who's below 45, that should click in your mind, this is hypertrophic cardiomyopathy, or any of the other variants that we are talking about. Professor, any points that you would want to add, I think, because you are been doing this over last 2.5 decades.
No, definitely. I think you have covered almost everything for this particular audience. Again, this genetic counseling is really the major part today, like to give awareness, impact, and everything. Again, this is an opportunity for the audience to learn from here and then.
Yes. Thank you. I know it was a very intense talk, but then there was no other way. I had to cover it because most of you are.
Each section can be a separate lecture.
I swear, absolutely. But I think I should thank that I learned what till now as a cardiologist I was not aware. With this talk, I think at least I have become much more aware. So thanks for the opportunity and thanks for inviting me.